Thank you. Thank you so much for being here early morning. I'm already kind of speechless, and being here, I'm truly honored to be here today and receive this wonderful award. My sincere thanks to the award committee as well as the AAO Foundation. So it isn't just a reflection of my effort, but it also the reflection of all the dedications of my former and present lab members, as well as excellent group of collaborators. I take this very humbly and inspired to continue to working even harder. I might die, but so it's truly honor for me. So I chose this topic, personalize or customize or individualize. This is one of my favorite words during my research career. And part of the reason is because I truly believe that this is the future of medicine. So medicine has to be done at the level of individual patients. So that's why I have so much passionate about this topic. So quickly, commercial relationship disclosure, especially my relationship with the Ovid has a direct relevance to the topic I'm going to talk about today. And I have research grants from various industry partners. So let me take a little moment to express my heartfelt gratitude to my PhD advisors, Dr. Nakatsuka and Jizuno, who really taught me basic optics and physics when I didn't know anything about these things. And they were very patient, guiding me toward the right directions through the entire my PhD journey. And I really thank them for their endless support. And I was working on this giant laser system, high energy laser system for fusion experiment. So this government facility has a very ambitious goal of creating artificial sun on Earth as a new energy source. So it's been going around for more than 50 years, and it's still going on. It costs a lot of effort and resources to get this thing going. So I was very proud of being part of this. And then toward the end of my PhD program, I had a chance to meet Dr. Williams at an international conference. So back then, I didn't know anything about the eye, vision science. I haven't even thought about the eye as a part of my future research topic. But he was able to convince me that eye research has a lot of optics components, and he uses a laser, and he was able to convince me, and that's when I decided to do postdoc in his lab at the University of Rochester. And with his, again, endless support and guidance, and I actually fell in love eye research and vision science. And to be honest, I plan to have a postdoctoral training for a couple of years and go back to my country and become a professor at one of the universities. And that I wasn't really that serious, but I just decided to give it a try and see what happens. But again, I really fell in love, eye research and vision science. And then I moved on as a faculty member and started my own lab at the University of Rochester, Flower Institute and Institute of Optics and Biomedical Engineering for the past 20 years. I had again, very big goal. As the video clip mentioned, I really like to see the outcome of the research in terms of helping people. I want to see where my effort go and help people, how that effort help people. So for the past 20 years, I've been developing various research programs before I moved to Houston 3.5 years ago. So this is my second chapter, I guess. University of Houston College of Optometry has excellent group of faculty members and staff who are very, very supportive and enthusiastic about doing collaborative research. I've been really enjoying being part of that group, and hopefully I can continue to contribute some more. So speaking about David Williams, he is also very, very famous in ocular wavefront sensing and as well as adaptive optics. He's a pioneer of this field, and he's the one who first took this technology from traditional optics field and applied to the real eye. And this research, opens up whole new possibilities and changes the way we understand the optics of the eye and how we correct the visions. So, a lot of, interesting findings from his lab. One of the most important thing is that the human eyes, even if you have 20/20 or 20/15 vision after refractive correction, human eyes are not still perfect. So they found that a lot of complicated shape of aberration called the high order aberrations left over that still limit the quality of your vision. So if you could correct those aberrations, you can actually achieve much better visual performance than what we normally say. And the other interesting thing they found is everyone has different types of high order aberrations and with a different magnitude. So what it indicated to me that we need to measure individual high order aberrations and correct them to provide or to optimize the visual quality. So that's how this whole new research is started. And the first project I did in his lab is to use adaptive optics vision simulator to evaluate the visual benefit of correcting higher order aberrations to prove that we really need to correct the higher order aberration to achieve the optimal visual performance. So adaptive optics, as you may know, is a very powerful tool that measures aberrations and correct the aberrations in real time completely non-invasively. So basically the system can make your eye optically perfect without doing surgery, without touching any part of your eye. So I used that system in his lab and proved that correcting high order aberration actually improves visual performance, such as visual acuity and contrast sensitivity. And the other interesting thing I found is that we all suffer from chromatic aberration. We don't normally correct or consider correcting chromatic aberration, but if you are able to correct chromatic aberration, you can actually have the limit of human vision, 20/10 in visual acuity, for example. So this result and wavefront sensing technology drove this whole new application of laser refractive surgery. So all your laser refractive surgery wasn't based on any knowledge of wavefront. So it's based on how much tissue we need to remove to correct their refractive error. But with this aberrometry and new laser system, we are able to improve the surgical outcomes quite substantially. Not only that, we also are able to understand why there are patients who dissatisfied with outcomes. You can actually objectively assess the problems that those unsatisfactory patients have. So this is one of the textbooks I really like, published in 2001, first book talking about the customized corneal ablations, edited by Dr. McRae and Dr. Kruger and Dr. Applegate. So the reason I really love this book is this is a true representation of collaboration between clinicians, scientists, and engineers. This is not just a book published by clinicians or scientists. This is a really collaborative effort from those important groups to make something really happen very different way. So I still remember to spend hours and hours to try to explain what the wavefront is to the clinicians. I'm pretty sure they had a hard time to explain me the clinical problems back then. So we're going back and forth in hours and hours and without any conclusion. You spend a lot of time, but you don't feel you learn anything. But if you keep doing the same thing, eventually you understand each other. This is a very, very important aspect in my opinion. And I think medicine has to be going this way. That's my strong belief. And since then, the laser refractive surgery technique has been evolved quite a bit, and there are a lot of new advanced treatment, like a wavefront guided, wavefront optimized. They're really good at creating all these different names. But as they do more, the outcomes of refractive surgery getting better and better. So I just read the review papers saying that more than 90% of the refractive surgery patients, their spherical equivalent is within plus minus a half die of the target refraction. And this satisfaction rate is extremely small. It's only 1.2%. So I'm sure this result will get better and better as we make more contributions. So then when I started my own lab, I started thinking about, how can I help people see better? And I had a chance to learn corneal pathologies, such as keratoconus and corneal transplant. I immediately found that these people have really large magnitude of aberrations, which actually limit their daily life every single day. And they can't drive at night because of all these double and triple images. When I saw that, when I learned that, and I decided, well, this is a topic I want to jump in, so that I can use my expertise to help these people see better. So, obviously these people are not a good candidate for laser refractive surgery, so we have to find the practical form of correcting their high-order aberrations. So we start with the simpler form, spectacles, and we move on to the soft contact lens, and we nowadays, targeting scleral lens quite a bit. Maybe eventually we can do the same thing with the intraocular lens for both normal and highly aberrated eyes. So in this effort, there are long-standing colleagues, Dr. Applegate and Dr. Marsak, have been putting a lot of good work around the same topic. So we've been always discussing about our outcomes and try to improve, how much better we can do with the same ideas. So we end up doing this scleral lens as a candidate. Part of the reason is the scleral lens is so stable on the eye. Part of the limitation of the spectacles and soft contact lens, when we try to do something like this, we just can't predict the movement of the contact lens on eye, or you can't predict the changes in gaze when they wear spectacles. So I thought this is a fantastic lens. This is another good example of how I learn these things from very enthusiastic clinicians. Dr. Perry Rosenthal, unfortunately, he passed away. I was thinking about him, last night and this morning, and preparing my presentation. I get very, very emotional. I had so much fun with him working on this project, and he and I got together and talked about each other's problem. Same thing. In the beginning, we couldn't understand each other, but immediately we see the value of each other's expertise. We decide to go for it. And this is one of the few clinicians who decides and pushes really hard to make it happen. I'm still missing his enthusiasm still. I really hope that he's still around so that I can talk to him, I can work with him. But I guess, our life is not forever. But I really like to thank him for his contribution to this. And he's the pioneer of developing this gas permeable contact lens material. He's the start point of all these, fancy RGP and scleral lens materials. So this is just a quick snapshot of how we design this wavefront guided scleral lenses. And so we have a more or less clinically oriented aberrometer in the lab, and we measure the aberration accurately, and our baseline lens has a laser marking on it that tells us where the center of the lens, rotational orientation of the lens, as you can see in this image here. And then we put correction profile on the locations of the lens based on the lens decentration and rotation with respect to the pupil center. And then we use the conventional laser cut to develop the scleral lens. So we were able to correct most of aberrations from very high level to the level that normal, healthy eyes have. And we thought, well, they should be able to see 20/20 vision because their optics now is very similar to normal levels. But what we found, we saw the improvement, definitely, but we found that their visual acuity is far worse than 20/20. So this actually initiated a whole new series of the project, and we came up with a hypothesis to explain this deficit after correcting aberration, which is a neuroadaptations. So we're going to talk about this in a minute. But sort of summary, there are still few factors that have a significant impact on successful correction of the vision using the wavefront-guided contact lens. As I mentioned briefly, contact lens has to be very stable. This correction method is static. If anything changes in time, you cannot correct. So that's why we like to have a very stable lens on eye. We need to have a very accurate aberration measurements, and we need to know the position of the lens so that we could actually use that information to decenter and rotate the correction profile. Finally, we have to make the lens very precisely. So we're talking about micrometer level accuracy when we create these lenses. And quite often, when we develop the technology or methodology in the lab, if we want to push it further to help the patients, we like to see it commercially available, right? We can't really recruit all these people to the lab and prescribe these specialty lenses for them. It's going to be a very small number of populations. So we need to come up with a clinically viable, robust system that can do all these complex procedure by itself. And luckily, one of the former students in my lab was interested in starting up a company. And he took this concept and started a company, and has been doing great. They have a system that has Optometry and has a software platform that allows us to design this wavefront guided contact lenses. And what a perfect time. The study led by Dr. Gallis is about to be published, just accepted in eye and contact lens. To my best knowledge, this is a first clinical study that testing the wavefront guided contact lens in a completely clinical practice environment. So as you can see here, most of high order aberrations, almost all the high order aberrations were effectively corrected by using this system. Full disclosure, I have a financial interest with this company, so I might be biased to this research. Please keep in mind. I want to be very clear about that. But I hope to see more companies, putting some resources and effort toward this direction so that more people could benefit from this technology. Just like a laser refractive surgery. Now is the time for the optometry community to get the benefit from this technology. And I love to work with the clinicians. And I can go back and spend hours and hours to explain the concept of this technology to you, as long as if you're interested in this technology. So that's a past and present. I'd like to spend some time to talk about the future now. I think in some sense the future is more important. What can we do based on what we learned? So neuroadaptation we briefly talked about. And I think a presbyopia correction is also a great example that could get the benefit from personalized wavefront-guided vision correction. And myopia development and control, a lot of groups, and there is huge momentum toward the better research and development in this topic. I think a wavefront technology could contribute quite substantially to this field. So neuroadaptation, this is also a hypothesis we came up with based on totally observations. So when we measure this severe keratoconus, and when you look at the aberration, you would think this person is almost blind. There's no way for them to see even 20, 40, 20, 60 visual acuity based on the optical theory. So we scratch our head, how come they could see 20, 30 with this lousy optics? It turns out that brain does a really good job at compensating some of the optical blur induced by the poor optics, so that actually perceived image quality is better than what optical theory could predict. That's very interesting. But what happens when we get rid of this poor optical quality by using refractive surgery or contact lens? What happens now, your brain is not ready to appreciate that huge improvement in optical quality. So you actually see worse than what you predict from the optical theory. So we constantly saw this kind of a pattern, and natural question is whether their brain could be readapted to this substantially improved optical quality. So we have a series of studies trying to address these questions. So presbyopia correction, is no longer someone else's problem. It's actually my own problem. So I, start getting this presbyopia problem. I can't really handle this, carrying multiple reading glasses to see computer monitors and to see students in the classroom. It's a very, very inconvenient thing. So it naturally gives me huge motivation to develop something different so that I can overcome this presbyopia problem. So a lot of options out there, and some limitations. Bifocal, diffractive, refractive. They have a very discrete range of the vision. Or if you use the spherical aberration, you have a very narrow depth of focus. So people really don't like this kind of characteristics of a presbyopia correction. So we came up with this very simple idea that starts with the power profile, which is actually repeating across the pupil, so that we could actually minimize the pupil-dependent performance of the lens. And also we use this different power profile to customize to individual needs. Some people might need only 2 diopter, very good quality. Other people might need only far and near. So we can easily customize the profile of these lenses. So, and the concept is exactly the same. So we use the same procedure for wavefront guide contact lens, but we just simply need to add this EDOF design to improve the presbyopia performance. So I'm actually wearing these lenses now. So I've been wearing these lenses every single day, and getting the benefit from your own research is actually pretty cool. And I hope that more people could enjoy this continuous depth of focus visual experience, so that they can overcome their presbyopia problem. And myopia development is another thing. We've been measuring the optical aberrations along the central visual axis, but past over the many excellent research, there's an indication that the peripheral optics might have some interesting contribution to the myopia development. So we start questioning what kind of quality we have in the periphery, and we developed this wide field scanning aberrometer that can measure now aberrations along at any retinal eccentricity. So we can actually map out optical quality across the three-dimensional surface on the retina. And from this, what we found is that in the periphery, we just don't experience a simple defocus, hyperopic or myopic defocus. We actually experience very oriented optical blur. Sometimes it's vertically oriented and horizontally oriented, depending on the sign of defocus you're experiencing. So we hypothesize that this orientation of the blur could provide a cue to the brain in detecting sign of defocus. So if you have a wrong orientation of the blur, that might accelerate central eye growth. And the other thing is chromatic aberrations. And as I said earlier, we never really consider correcting chromatic aberration, but there is a potential to correct it. So if you use a diffractive optics, which has opposite sign of optical dispersion, so if you use a diffractive optics and combine it with the positive dispersion of the eye, then you are able to correct chromatic aberration in natural white light conditions. So we proved this concept in the lab. Thank you. Yeah. And we found there's a very large potential of using this idea for simply vision improvement and as well as myopia research. So I'd like to finish my presentation by proposing this crazy idea. And if you use a femtosecond laser, you can actually create the aberrations inside the contact lens material by using two-photon and multi-photon absorption. Maybe in the future, your patient could wear a contact lens, and we shoot the femtosecond laser and create the perfect profile to correct their optical problems. And we could also control the biomechanics of the cornea. So we're very excited about this, and I have so many people to acknowledge for my research career, and Dr. Applegate, Dr. Buns nominating me for this award, and UHCO faculty and staff, including Dean Toa, welcoming me to UHCO, Dave making this a wonderful video clip, funding source from NIH and NEI, and so many former and present lab members and collaborators. I should spend time to create the list of all those people, just like what Nathan did, but I guess I was too lazy. I'll do that next time. And I'd like to close my presentation thanking my family, my wife, Ju, who I think has a lot more talent than I do, and she could have been much successful businessman, an artist, and whatever, but she sacrificed her career for me and our family, and my two kids, Geunyoung Yoon, who's a faculty member as an OD at UIC. My son is an architect in Atlanta area. I'm so proud of both of my children. Thank you very much.